Thanks, Rob, for the opportunity to talk about our experience at Mount Sinai. As I introduced myself before, I'm Denise Prince, and I'm honored to be kind of the intro to the main event here, which is Shoshana and Ashley. I wanted to just give you a little bit of background about our organization and our context to help you understand kind of why we took the approach that we did. We operate a clinically integrated network, probably similar to a lot of yours, where we have thousands of physicians, the hospitals within the Mount Sinai health system. We're about a $9 billion system, and we have 8 main full service hospitals. We have 4 in Manhattan, 1 in Brooklyn, 1 in Queens, 1 on Long Island. And we have over a dozen value-based contracts. They cover about 450,000 attributed lives. Out of those 450, 120 are full risk. So we have over 100,000 full risk Medicaid lives, which for this topic is pretty pertinent. We have about 30,000 Medicare Advantage lives and about 45,000 MSSP lives. So everything we're going to talk about, we try to apply to all of our value-based contracts, but I think the reality is that where we're at full risk is where it matters most, to kind of Len's comments just now. So we've been on this value-based contracting journey for several years, and probably like your organizations, we've done some of the basic kinds of things that everybody does, right? We have a provider engagement team that goes out and meets with physicians and talks about gaps in care and medical home and how to coordinate care. We have a quality department that monitors how we're meeting the metrics for our various contracts. We do utilization management. We, of course, have a documentation and coding department. So some of those real fundamentals that you need for value-based contracting were already in place. About 4 years ago, we started a whole post-acute strategy where we are working on utilization of skilled nursing facilities, kind of basic length of stay most recently, over the last year, we've started ambulatory home health referral coordination, which involves a lot of social determinants work. We'll get calls from primary care doctors saying, my patient needs something in the home, something has changed about their condition, and I want visiting nurse. But once you probe what they really need, you find out that it's really a lot of social determinants kinds of things, that they're homebound and really it's a transportation need, or there's a homemaker need, or there's other kinds of challenges in that home. And so we've had a lot of success in directing people to the right community-based services. And when they do need home health, we direct them to the right place there too. But even with all of that, there were still some real gaps in our population health management approach. We had a gap in behavioral health and the whole referring process, the whole recognition that a lot of behavioral health care happens in the primary care office. So we developed, we have a fledgling department to address behavioral health within pop health context. We've been working on condition management, remote patient monitoring, those kinds of things. But one area that we just felt needed its own department separate from our very large care management department was social determinants. We wanted to develop it apart from our care management group, which is composed a lot of social workers, care coordinators, nurses, and we integrate the pharmacists as well. And I think a lot of organizations think, well, we're just going to build this off of our care management structure, and we'll put who's ever in charge of social work, and that will be the person that relates to all of these folks that Len just talked about. But Maybe it's because of my venture background. I started and ran the venture group at Geisinger for 9 years. And so I got used to startup and accessing funds and coordinating with lots of partners and doing a lot of legal work and transactions. And I realized that this was really going to be no different than any other venture, that everything that Len just talked about requires a really different skill set. So all of these things that we do in population health within the context of our ACOs, whether it's utilization management or quality management or post-acute management or a social determinant strategy, it's all around avoiding unnecessary utilization and improving the cost and quality of care. So we thought, well, we need to add this to our group. We need a lead. And so what exactly were we looking for in that person? And we created a very robust job description. It said, we don't really think we're going to find all this stuff in one person, but we're going to try. And it turned out that at the time, it was one of the hottest jobs in healthcare in New York City. We got many, like over 100 applicants for the job, because it's I hope Ashley thinks it's a cool job, but I thought it was a really cool job. We were looking for somebody who was really good at communication, which, like, what job doesn't need that? But as we just heard from what Len had to say, there's a particular collaborative skill set. It's not just communicating with your colleagues in your own work unit or across your organization. It's communicating to people who are coming from very different mindsets, from community-based organizations or from payers or from funders. And so this ability to be adaptable and politically astute, kind of carry your own weight, whether you're talking to a CEO or a community health worker, or as it turns out, a lot of data people and compliance people and IT people and vendors. Communications and the ability to assimilate information was really the most important thing. We thought, being a big health system, we have a long history of poor performance, bad behavior with respect to our community partners. We don't mean to be morons, but we often are. And it's just because we're big and clunky and we have a lot of different agendas and we have a lot of constituents, and sometimes we just don't get our act together. And so when you're approaching community partners and they're like, ah, well, we remember you guys. You guys said you would do this, but you didn't really do it the way you said, or you know, we tried something and it didn't work, or it fizzled, or you made us go to 1 million meetings and nothing ever happened. You know, that's kind of where we were. If I see some nodding in the audience, apparently Mount Sinai was not alone in subjecting our community partners to this. So we thought it was really, really important to have the leader, the director of our community health innovations and partnership group be somebody who had been on the other side, that they had something other than bureaucracy experience, that they had passion about a particular social determinant, so they could understand where people were coming from with their drive to just get something done. Having some experience with the financial part of it, whether it's writing grants, creating financial models, being able to create a budget and manage to it, that whole financial piece was really important to us. As I've alluded to, just general management skills beyond just what you have to do from a single function. This is a lot of project management. It's a lot of detailed tasks that have to be interwoven and done at certain times in a certain sequence to get something done. We put, as you'll hear from Ashley, we put a big emphasis on analyzing our data to understand where the needs are, where we can possibly have an impact. And so the ability to sit across from an analyst or set of analysts and talk about how does data become information? What's useful to us? How do we get the insights we're looking for from the data that's available to us? That kind of competence is really important. There's a lot of legal documents in our work. I just didn't anticipate how much time we would spend talking to lawyers and compliance people about who we could share the data with and how it could be shared and which kinds of BAAs were necessary and all that whole thing. When you're in the startup phase and establishing new partners, and as Ashley will talk about, establishing a network, spending a lot of time with the lawyers and compliance folks, and then in negotiations. And finally, and certainly not last, the whole strategic orientation, because I have a saying that everybody in my group, maybe Melanie remembers this from when I was at Geistinger, but I'm not a big fan of science projects. And by science projects, I mean things that you kind of start doing in the course of your business because it's cool and fun and you want to prove a point, but it's not really going anywhere, right? It's not ever going to be part of your future operations unless, a fluke happens. But sometimes science projects do end up as something real. And it's not that I don't like doing any science projects. I just don't want them all to be science projects. I want them to be strategic. I want them to have a future. And so the ability of the director to say, oh, that's a interesting opportunity, but it's a science project versus this is a fundamental strategy that will help move the needle on what we're trying to do with our value-based contracts. And out of these dozen opportunities that we have, these are the 2 or 3 that we ought to do this year. It's just a really important kind of competence to have and to be able to engage with other leaders on that. So we were really lucky that we actually had Ashley on our team after doing this sort of citywide search, interviewing all kinds of people. Like I said to my colleague, it's like, really? She was right here all the time. And I just didn't realize that she had all this kind of competence to her, but it certainly has shown in the last 18 months that we've been working together. So I'll let her tell you about it.
Thank you. I'm very excited to talk with all you guys. Hopefully, since I shared an embarrassing story, I won't need to embarrass myself anymore. But I think I would guess from everyone's experience that it's not a given that we have leadership buy and support. And so I think that goes a long way to sort of being able to do some of the stuff that Denise and our other leadership had set out for us. When I started in this role, which was in January of 2020, MSHP had launched this department. They sort of, with this very long job description, wanted to come up with sort of a sustainable and a standardized way of addressing social determinants. And then to do that through some innovative partnerships that increase health equity, lead to improvements in health outcomes, and result in more efficient use of resources. I started sort of formally with the priorities of really establishing the department because it was new, gathering information. We're a big, huge health system, so we wanted to know who's doing what already, what information already existed, and what did we need to figure out. Building internal and external partnerships. And I think to what Denise alluded to, in some cases, rebuilding probably should have been included in there. Piloting some initiatives, and then really thinking about identifying, prioritizing the needs. So kind of going back to that data that Denise mentioned, there's a lot of stuff that we probably want to do, but sort of figuring out how we can make decisions about what we actually need to do and should do first. And then just because of the timing, thinking about the alignment sort of with our COVID response and the other work in the community. This is it's a high level overview, and it seems pretty straightforward, but it took a while to figure out all the pieces. And then, I'll go into a little bit of an explanation around sort of how we're doing each of these. And you guys all submitted profiles. And so we did try to take a look at them just to let you know that we read the stuff that you send. And I will say, it looks like 5 out of 14 of you currently have somebody who's a dedicated FTE to the position. So that's a start. In terms of having a strategic plan, it looks like one of you is in the concept phase. You've got 5 in the planning phase, 6 in the implementation phase, and 2 in the scaling. So a little bit of a mix of backgrounds. For us, when we were kind of taking a step back, we realized first thing is really identify the needs. So what are the needs in our community? What do we know? What do we need to know? And then try to couple that with a resource. So we didn't want to end up in that sort of classic problem of you assess, but then you can't treat. So we wanted to make sure we had resources to go along with that. As we were thinking more and more about the resources, it became clear that we really wanted to have a preferred network of CBOs. So we wanted to know not just sort of who does what, but how can we actually make closed loop referrals to those CBOs so that we know when we've sent somebody out to get a service or some sort of support, we get information back. And that way we could track the impacts and the outcomes and then ultimately sort of do the advocating for the systematic change, both within the system and within our own department, but at a city and a state level as well. So when it came to assessing, I think MSHP or Mount Sinai, tends to be very data driven. And so when I got into the role, I thought, okay, let me just go to the data and then we'll see what the issues are. We'll partner that with resources. It'll be really straightforward. We'll just get it all done. Really early on, it became clear that we didn't have sort of a concrete data set that we could easily pull from. We needed to get a better understanding of what the landscape was around community needs. So we've sort of had, like a push, pull, and a sweep approach. We're like, one way is not going to get it done. We need a lot of information. So the first thing was getting a standardized SDOH assessment. So we went about this by evaluating a patient's social needs in 17 different categories. Right now, it's primarily completed by our social workers and our care management. A big component was making sure that it was embedded in EPIC, our EMR, so that if that information exists, it's existing someplace where it's accessible by more than just one person. And we did go through the exercise of aligning the questions with the existing Z codes, kind of hoping that further down the line, if there is reimbursement for the Z codes, we wanted to be in a good place to kind of structurally prepare to be reimbursed. Next, with the realization of, okay, not everybody has had an assessment, we wanted to actually look and see whether there was some commercially available or vendor data that we could supplement that would give us maybe a high level understanding of the needs in the community. So we created, our brilliant analysts sort of created an RFP that they developed and posted, and then we vetted different vendors to see what they have. And then ultimately, like I mentioned, sort of bringing that back so that we can get an understanding of the aggregate trends that allows us to really do that prioritization of, there might be 100 things that are needs, and there might be 100 things that we want to do, but what will really have the most impact in our community. So we did pick a vendor that has about 5,000 unique metrics, 128 risk and engagement scores. And in all honesty, I would say we're still sort of digging through that information. It's great to have a ton of data, but then figuring out what are you actually going to do with it and how's it beneficial is the next phase that we're in. And then the last part was sort of a recognition of there's a lot of assessment that we can do internally, but we also ultimately are going to need to push some information out to community members. And there might be some circumstances where people feel more comfortable filling the information out sort of in the comfort of their own home or elsewhere. So we did create a questionnaire that can be pushed out through MyChart, the patient portal, and Epic. And then when the information comes back in, if someone does flag positively for a need, we can then use some of the other mechanisms around our referrals and things like that to connect them with community-based resources. We've been just working with Epic recently to make sure that some of this SDH information is reflected within the EMR. So just sort of a snapshot for those who might be on Epic or sort of interested in seeing how it shows up, that, hopefully in that landing page for a patient, you can really see what the resources are and have it become sort of readily available information. In terms of the kind of thinking about resources, we wanted to both leverage our existing partnerships with CBOs, but we went through the process that I think some of you have already started to do. I think I saw 4 of you are using Aunt Bertha, 4 are using Unitas, 1 is making referrals through Epic. There are 4 of you that are using some other platform, like I think there's the NYC Cares 360, there's some other things. And one that I think is still in the deciding phase. We decided to go with Aunt Bertha because of the potential for Epic integration. I will admittedly say when I've talked to every other health system that picked a platform, they went with it because of the Epic integration or some sort of EMR integration. We've been utilizing it in a couple different ways. I think one thing we've come to understand is it's both a community resource guide and then also a platform that can track and make referrals. So right now, anyone with a Sinai email can access Aunt Bertha directly through Epic. So there's a link, and I'll show you guys that next. And then you can also log on to their external page. So if you're someone within the system who's not an Epic user, you also have access. And it's a Sinai branded platform. So it looks like a resource, but it leverages a backend from the Aunt Bertha organization. During COVID, we also realized we needed to be able to push out more resources into the community. So we worked with them to get a patient-facing portal set up pretty quickly as well, also so that others could kind of go and research at their own pace. And then we're working to do more of an Epic integration so that the data that we get back from Aunt Bertha on referrals can go into Epic and can live in a sort of more consistent place. So here you can see just sort of a snapshot of where you're able to click on the community resource guide, and it'll launch a native page within there. The type of searches you're able to do kind of by keyword as well as program or zip code. It looks very similar for the patient-facing page as well as the staff-facing page. And then some examples of the ways that we're able to share information. So ideally, we want to get to that closed loop process. And I'll talk a little bit more about the CBO network that we've been developing to kind of create a more standardized referral process. But there are a lot of CBOs that are listed on there, and you can click to share the information, or with the ones that are actively receiving referrals, you can fill out the information on the right side. You do get the patient's consent and it'll send it directly. And then when that referral is received, we get some sort of acknowledgement that that loop has been closed. So I think as we were looking through, like, New York City is a pretty densely concentrated place. We're thinking about all the resources that were available for the, it was great that there were so many things on Aunt Bertha, but at the same time, we needed to narrow that down. And we also wanted to create some expectations and requirements around what our CBO partners will do. And, Shoshana will talk a little bit more about sort of some of that partnership has been like. But we realized that we wanted to have sort of a preferred network of CBOs that we worked a little bit more closely with, and that we wanted that to initially leverage some of the existing relationships, but to move from this sort of historical relationship into something that was much more data driven, that we could look at the needs, we could create a process where we sort of have an open call for partners, we have standardized ways that we track our engagements with them. So we wanted to create this network so that we had, a healthier, more equitable CBO network that addressed social determinants, create sustainable partnerships. I think when we were talking with folks in the community, what we heard from them was, we love to partner with health systems. We love, the clinical work, but we're always chasing grants. So we're trying to do this. Like, you guys seem like a good opportunity in terms of more sustainable funding. And we also have access to some philanthropic, but a lot of non-philanthropic funding sources like payers. And so there was interest in, how can we bring you in formally so that when we're talking to our payers, we can bring up our CBO partners and hopefully get them to reimburse directly for some of the services. And then the last thing we heard from the CBO partners was, we have this pretty robust data and analytics infrastructure of how could we make some of that available to our partners so that they could think about tracking the work that they're doing. They could use it for other fundraising opportunities and things like that, and generally just share that back. It's a lot easier for us in a lot of cases because we have access to claims, we have access to so much patient information and things like that. So the goal was, as Denise mentioned, we had this clinically integrated network that was solely based around clinical providers, was to think about how can we create a structure that looks very similar to what we're doing with providers, but applies to community-based organizations. So we wanted the CBOs that were joining the network to contract directly with Sinai the same way that our providers do. So they have that same sort of inclusivity, and we have the ability to negotiate with payers down the road, hopefully, to complete some additional vetting so that when we were in those legal meetings or when we're talking with the various concerned compliance or legal folks, we could say, this is not just any old CBO. We've done sort of a more robust look at, what their financials are, the quality of their services, And they've committed to some, what we've called sort of standing business requirements, things like, when they'll refer, what platform they'll use to accept referrals, how quickly they'll respond, and things like that, so that we're standardizing some of the work that we do. Ultimately with the goal that we can more effectively serve our communities and actually address social needs in a way that's trackable. This is a little bit of an overview of what the CBO process looks like. Like I mentioned, we're trying to move away from like historical relationships and have something that's very data driven. So we identify need within the community. We are working to announce an open application. We actually just had one that we're wrapping up right now that was relatively open in terms of the types of needs. But I think going forward, we really want to do things that are more targeted to say, hey, we need more food CBOs, or we really need to focus on transportation or something like that. Have the CBOs submit, the applications reviewed by an internal committee, and then invite the CBOs to participate that sort of pass the initial application process. And then do that vetting and credentialing, similar to what we do with our providers, and then have any, CBOs that make it through that point actually contract directly with us, and then work with them on some mutual collaboration and kind of continual KPI tracking. Like we already started to talk a little bit about some of the ROI and the tracking. We wanted to get data back, but I think the other thing was trying to think at a high level. How do we track all this information? How do we standardize what we're doing? So in addition to bringing the CBOs on and sort of asking them for regular metrics, we've started to look at what North Carolina did with their Medicaid waiver and say, okay, well, if we're going through this exercise of identifying needs, let's prioritize maybe the top 3 or 5 or so. It's one thing to know the need area. I think the next thing is actually to select interventions that you think are going to effectively address those needs. So we've been trying to align the needs. So it might be food security is your need area, or food insecurity is the issue. What are you going to do with that? We talked a little bit about medically tailored meals. Can we get a standard intervention or description so that we all know what we're meaning when we say a medically tailored meal? And then beyond that, say, okay, well, let's talk about what impacts we really think, or what metrics we think really connect to these services. And there's probably an endless list of metrics in the way that there's an endless list of social needs. Let's talk about the ones that are really important to us, and can we document those and then begin to have a standardized process by which we contract and track information. And then the next thing, the reimbursement of, so what do we pay for these services? Is there any sort of way for us to standardize the fees? In North Carolina, what they did was they actually asked the CBOs to submit to them. They looked at any case where there was an existing Medicaid feed, but they asked the CBOs to actually submit what their costs were, and then they had their sort of actuarial services go back. So we're trying to do something similar where if we know the cost of a standard medically tailored meal, or we know this cost of an intervention, let's get that down on paper so that we can begin to get a sense of what we might be willing to pay, and then develop some cost profiles and comparisons, like I think Len was talking about before a little bit of, if we know this is what it costs for this group and we can compare, is there some way to track the ROI or the total cost reductions for those groups? Probably at this point, if you're Denise or the rest of you saying, Ashley, this is extremely lovely, smart art that you've put in here, and it's a nice high level strategy, but what have you guys sort of actually done in terms of implementation on the ground? And so, at some point when I, came to Denise and, had these ideas, it was some decisions around what do we actually want to focus on? What does that translate to into priorities? And so at the time, we wanted to do things that we thought we knew were needs within the community. We thought we could effectively prioritize and that were COVID relevant. And so we landed on these sort of 2 pillars. One was food security, and the other was a bit of a broad umbrella around equitable access to care. And I'll show you how that breaks out a bit. So in the equitable access to care, because this sort of spun up right in the height of New York City's peak with COVID, we wanted to make sure that we were doing outreach to vulnerable communities. And so we actually partnered with AIR NYC, which has a group of community health workers, to reach out, to call people at home, to let them know what services were available, to screen them for food insecurity, connect them to resources if they needed, and talk about what the current sort of treatment or healthcare options were around COVID. And then also to provide any supports around sort of behavioral health, safety, mental health, well-being. We also did that in terms of texting, just to reach a larger cohort of patients, sort of focusing on using different risk stratifications to pick those that we thought were the most vulnerable. We've also been looking a lot at telehealth disparities. So again, with ARNYC, we're focusing on some of the interventions we did with them. We looked at patients that live in public housing and had either no utilization or very low utilization of telehealth, but some level of deferred care, and used the community health workers again to reach out and do sort of an education and awareness campaign where they let people know what kind of telehealth options were available. And if people wanted to schedule something sort of live at that moment, the community health worker actually worked with them to set up an account and get something going. We've been building out, we've been calling our community health hub. We had a school in the area that had a relatively high attribution of patients and had expressed a lot of needs around behavioral health, primary care access, and social needs. And so we worked to sort of co-develop a community health needs assessment to deploy it and then create specific resources that are aligned with that. And I'll talk a little bit more about that on the next slide. And then the last one, sort of under the equitable access umbrella, was to provide legal assistance. I'm going to come back to that one too on the next slide. And then for food security, we've been focusing on emergency food assistance, particularly because of that potential readmissions penalty and having the opportunity to kind of catch someone who might be going home to an empty fridge and make sure that they have resources. Medically tailored meals, for the reasons that everybody brought up, there's sort of the most research available on that one in terms of ROI. So it seems like a smart place to kind of make investment. So for the Community Health Hub, we partnered with ARNYC and a charter school in Harlem to deploy this assessment and to create really clear referral pathways. We actually sort of virtually embedded the community health worker within that school so that they could provide care navigations to students and family members to improve their access to primary care, behavioral health, and social needs. And I would say what has been one of the most effective things is, as we identify the need, we created really clear outcomes and pathways. So the intervention was not time bound. It was really to achieve a particular outcome. So if somebody didn't have a primary care provider, the CHW could work with them until they completed their appointment. Or if they were overdue for vaccination, they could continue to work with them like until they get that outcome. And it made it easier for us to kind of track and report back on what we were actually able to achieve with the help of the community health workers. On the legal assistance side, ultimately, we're sort of hoping that our payers are going to be able to directly reimburse for some of those services. And in this case, we had some interest from Health First around actually directly providing some funding for an attorney. And the work was really to focus on, could we come up with a way to identify patients that potentially had a legal need? And so we took a list of legal terms that the legal organization gave us. We did a query of the entire EMR, and we saw anyone who was flagged, and then we had a care manager reach out to them, confirm whether they had the need, and then make a referral over to the legal assistance. And we're right now sort of trying to do some of that cost comparison of those who were referred versus those who had a legal need but didn't end up receiving the services. And that one has been going well so far too. I would say the majority of the issues have been around, I would say, housing and benefits eligibility, which we know, can have a direct impact on health as well. So in terms of next steps, I think sustaining and scaling the existing programs. I think we don't want to end up in a place where it's sort of the flash in the pan problem where we were able to spin something up and then it just sort of fizzles out. To leverage some of this new data to make more data-driven decisions. And then to provide non-clinical services to help our teams achieve their clinical goals. So a lot of the initiatives that we stood up initially, might have even sort of bordered on being a little bit siloed from some of the other clinical work that we were doing. So going into next year, really thinking about understanding the priorities of our department more broadly, and then of the health system, and thinking, okay, well, where can we layer in social services, whether it's with high utilizers or patients with chronic conditions that are diet impacted, housing, legal assistance, things like that, that can be really complementary to what we're doing otherwise. Scaling our CBO network, so really figuring out who are the other resources and CBOs within the community that we want to bring in as supports for our patients and for our other team members. And then sort of back to the trying to make some system change, sort of specifically identifying and engaging some of those policy and payer stakeholders around these discussions to be able to say, hey, look, we can figure out what the needs are. We have mechanisms for addressing them, and we can calculate some of the impact. Why don't you guys, do this and reimburse for these non-clinical services in the same way that you do that for clinical services? What would that look like? Take a risk on